All right. Looks
Okay.
like transcription has started. Are we set?
Yeah. Yep, it started.
Great. Thanks, Rose. So good morning, everyone. I am Siobhan Martin. I am the chair of the PEB board, and we are convening our May 16th meeting. It is going to be another busy meeting day with lots of votes to take place. So we are going to move through all of the items that were left outstanding from our last meeting as best that we can. Just want to encourage you all again to ask questions where needed. And we are moving toward our final decision making for the 2024 plan year. So we do have a packed agenda, even though it looks like there's only a couple things. That's because our final renewal decisions are going to take up the bulk of today. So I am going to start with roll call. Dawn Mottner, our vice chair. I believe I see you here.
Present. Good morning.
Good morning. All right, Greg, I saw you on camera a minute ago. Greg?
Yep, I'm here.
Great. Hey, Chicky, are you here? I have not double checked the participants. Let's give Chicky a minute. Chicky, are you here? All right, she may not be here yet. Andy, I see you on camera.
Yep, I'm present.
Right, thanks, Andy. And Kimberly, I see you on camera too.
Good morning.
Good morning. I know that Kate Nass is excused today. Sean Parkman, Sean, are you here yet? All right, Sean may not be here yet. We do expect Sean to come today, so there are 5 of us. That means we have a quorum to get the meeting started. I should name, I don't believe Representative Noce will be here, but I do want to double check since he's busy with the legislature.
Sorry, Siobhan. No, he won't be here.
Okay, that's what I thought.
He usually lets me know.
All right, thanks, Rose. All right, so let's go ahead and get started. We can do a warm-up vote with the April 18th minutes. And thank you, Rose, for sending out an updated version of those minutes. They came out either early this morning or late yesterday. Anyway, the latest version of the minutes are the ones that you all should be looking at. And I want to know if we have a motion to approve the minutes.
I can make a motion to approve as written.
All right, thank you, Greg. Do I have a second?
This is Kimberly. I'll second that.
Thank you, Kimberly. All right, so Dawn, how do you vote?
Approve as written.
Thank you. Just double checking to see if Chicky's here yet. Okay, Andy, how do you vote?
Approve.
Okay, and Sean, are you here yet? All right, we do, and I forget, do I need to vote on this just to make the quorum or well, I'll vote yes. So the minutes are approved and we will move into our final renewal decisions.
And Chicky did say she'll join as soon as possible.
Oh, okay, great. Thanks for that update.
All right.
All right. So Andrew, is that you leading?
That's me. I can get us kicked off here. Thank you, Siobhan.
Thank you.
And like Siobhan said, we do have a packed agenda despite the sort of slim agenda topics shown at the outset. But you know, we've got 2 hours for this piece. Given that we've got a lot of discussion, we'll move sort of quickly through some of the sections to ensure we're really providing adequate time for discussion for the third section, which if we can jump to the next slide, is where we'll look at these final outstanding decisions for the 2024 renewal. And so we'll kick things off as we always do with a recap of PEBB's vision for healthcare, as well as the health equity strategic pillars and long-term goals that help realize that vision. We will recap the decisions that were made last month before we sort of dive into the remaining 2024 decisions. So with that said, if we want to jump ahead, I know everyone is familiar with PEBB's vision for healthcare. This is organized in such a way to sort of be embedded within the governor's priorities related to healthcare. The focal point for PEBB's vision includes things like focusing on innovation, quality, and outcomes, educating members, looking at innovative delivery models, affordability for members, ensuring the richness of the benefit, all the good stuff that we talk about from month to month. And so, I guess what I'll say here is that as we're going through and asking you all to make decisions and vote on some of these items, just keep in mind our three primary areas that we're trying to influence. First and foremost, PEB membership. Secondly, the delivery system in Oregon, and of course, the needs of the plan sponsor and administrator itself. And so in terms of how we sort of start to funnel down, how do we bring this vision into reality? If you jump to the next slide, please. One way that we do that is through the, okay, I see Sean joined. Hi, Sean. One way that we do that is through the health equity strategic pillars and really centering decisions on health equity. As we're going through these remaining topics today, there's sort of varying degrees of equity considerations. Some of the issues have considerable equity implications. And so, throughout this deck, we've carved out time to really talk about some of those implications and how we can focus on trying to address potential inequities. PEB has also established long-term goals. And so many of the topics we're discussing today overlap with these goals. And so, some of that overlap is around focusing on behavioral health, again, addressing health inequities, focusing on whole person, keeping in mind that PEB has a diverse population, and so focusing on the needs of a diverse population. And again, always a topic, ensuring the richness of the benefit and managing affordability on behalf of your members. And so many of the topics today really focus on specifically those 5 or so areas. So I think if there are no comments so far, shift gears a little bit. I'm going to hand it over to my colleague, Sally Hill. She's going to take us through a somewhat concise summary of some of the decisions that were made last month. And so, Sally, if you want to take it away.
Thank you. And so Andrew said there are going to be places where we're going to move quickly, and this is the area where I will try to move relatively quickly, since this is a recap of conversations we've had in previous board meetings. So to start with Providence, there are 4 items that were accepted for 2024. You're adding a massage therapy benefit to the statewide plan, which will mirror the benefit on the choice plan. On the choice plan, eliminating the PCP referral requirement for specialty services. For all plans, adding a new utilization management process for physical therapy called EviCore, and then eliminating the exclusion for sexual dysfunction medications. So next, Maggie. And please interrupt me if you have any questions or comments as I go through these, because I'll go quickly. So on MODA, the accepted plan enhancements are to implement the Copay Max Plus program. And what this will do is ensure that the actual out-of-pocket expense incurred by the member is reflected in their out-of-pocket maximum and deductible. VERTA, which is a diabetes reversal program, so this will be made available to diabetic members. And then also eliminating the sexual dysfunction medication exclusion under the plan. And next, travel and lodging. So we discussed quite a bit a condition agnostic travel and lodging benefit. So for the 2 self-funded plans, they will have the same travel and lodging benefit. It'll be compliant with the IRS regs in terms of the daily limits for lodging. And it'll be available when there are under 3 different situations. One is when there's not an in-network provider available within 50 miles of the member's home. The second would be when it's not available in their state of residence due to law or regulation, when those such services have to be received in another state, and then if their services at a COE. The benefit will be limited to $5,000 annually. And then under Kaiser, it'll be going along with the standard Kaiser travel benefit, just expanding it somewhat in 2024. Hey, Maggie. And then on dental and vision, there were no plan changes across all carriers. MODA is going to see a 1.5% increase in administrative cost. Kaiser is going to experience a 2% premium decrease. Willamette Dental, no premium increase. And then BSP, there should be no change in administrative fee or benefits. And the one, not really a change, but a continuation on the Willamette Dental plan is going to be continuing the copay waiver for new patients. That'll continue to 2024. And then next. And then the standard. So the standard is renewing on the basic life and voluntary life and AD&D. There's going to be no premium increase. On the short-term disability, there will be a premium reduction that goes into effect September 1. And I do want to note that there was legislation passed to allow the Employment Division to delay implementation. And it would be delayed till December 1. We don't think that's going to happen, but we wanted to just make note of it. And if that were to happen, the premium reduction would be delayed to December 1 when they would delay, if they were to delay implementation. But we don't, at this point, don't think that's likely. And then finally, on long-term disability, there were increases across the plans ranging from 12 to 16%, which are illustrated here. And then next, Maggie, I think a couple more. Okay, so Weight Watchers, they're going to renew with no change in annual cost, which is about estimated to be about $1.5 million annually. And then due to the end of the COVID national health emergency, or public health emergency, excuse me, wrong one. The plans are going to revert back to contract benefits. So MODA and Providence will revert back to their regular contract benefits July 1, because that's what the the board voted on initially. And then the Kaiser plans reverted back to contract benefits May 12th. And then over-the-counter COVID tests, the board approved having the MODA and Kaiser plans, excluding those going forward, and then approved having the Providence medical plans continue to cover them. But we got some additional information on just Friday about Providence's approach, and they're actually planning on excluding them. So this is going to be something that will require board action, and that's on the next slide. So what Providence has determined is rather than continue to cover the OTC tests after the end of the public health emergency, they are no longer going to cover it. So we're recommending going along with their standard coverage and not covering them, which would be consistent with the other plans. And then under telehealth, this is really just a clarification. We showed that there was covered, that telehealth would be covered in full in-network and regular plan benefits out of network. And the reason we just want to bring this to your attention is that prior to the public health emergency, out-of-network benefits were not available for telehealth. And so we're recommending that you just, that the plan just maintain the same benefits as were in effect during the public health emergency.
So I just
So
have a
this is-
question about the telehealth piece, because we didn't discuss that last time. Is that continuing for MODA and Kaiser as well? Because there were differences around access to telehealth pre-pandemic. I know at least for MODA, maybe for Kaiser too.
I think they're both continuing regular contract benefits after the public health emergency. So whatever was in place will continue. I don't have them in front of me, and I apologize. I should pull them up, but see if I can.
I think the plans are on. We could ask them, Siobhan.
Okay,
Yeah.
that would be helpful to know. I guess we're also used to telehealth now, or I'll speak for myself. I'm very used to telehealth now. So was not imagining there would be a change here. So I was a little surprised that it's being called out. So is our
Well, I should
MODA and
clarify-
yeah.
Oh, I'm sorry. I don't mean to interrupt you.
Oh, I was
Well,
just going to say, I just wanted to ask about around MODA and Kaiser too, if they're going to continue to have the telehealth covered.
Hi, Siobhan, it's Sapari from Kaiser Permanente. Yes, we are going to continue to cover telehealth for PEBB at a zero cost. It was at a zero cost during the public health emergency and will continue to be a zero cost after.
Okay, thank you for confirming. And is that true for MODA as well?
Yes, this is Alina Rubisky with MODA, and that is correct. We're the same way. We'll continue to cover telehealth services. Right now is at $0 copay with a deductible waived for telehealth.
Okay, thanks for confirming.
Mhm.
And thanks, Sapari. Sally, you were going to say something else. Go ahead.
Oh, I'm sorry. Well, we just wanted to, really the intent was to clarify the telehealth benefit, because this is what we did illustrate before, and we just wanted to clarify that this is different than it was prior to the public health emergency. So that was really the point. So, but this will require a vote of the board in terms of the OTC.
Okay, thank you. Appreciate that. Do we have any more questions about this before I see if there's a motion to have the Providence plans be parity with Kaiser and MODA? We voted to not cover the over-the-counter tests for MODA and Kaiser in the last board meeting. So do I have a motion around this?
This is Andy. I'll make a motion to, however you put it, align the OTC with both Kaiser and MODA for Providence.
Okay. Thank you, Andy. So that's what's reflected on the slide, not covering the 8 over-the-counter tests. That would align with Kaiser and MODA. Do I have a second?
This is Kimberly. I'll second that.
Okay, thanks, Kimberly. All right, Dawn, how do you vote?
This is only for the OTC tests, correct?
That's correct. That's what the motion is around. I don't believe we need to make the vote on the telehealth, or do we? That's the question. Do we need to vote for the telehealth too?
Let me just double check what we presented to you. Well, what we did is, so what we had after the public health emergency was covered at applicable plan cost sharing. So we were just clarifying what the applicable plan cost sharing would be.
Okay, so it sounds like we don't need to vote on it. So yes, it's just on the over the counter. And so I have a first by Andy, second by Kimberly. So Dawn, how do you vote?
I'll vote to approve.
All right, thank you. Greg?
I approve.
Chicky?
I approve.
Okay, and Sean?
Approve.
All right, so the motion carries. Thank you, everyone. Thanks, Sally.
If I may,
Yes, go ahead, Dawn.
thank you. This is just an observation that I'd like to note about telehealth. The industry has undergone a massive shift toward telehealth in these last years. It was something that had been developed for many years before that, but in great measure, payers were resisting paying for it, and that's why it hadn't been adopted. From my perspective as a researcher in primary care and working in piloting some of the telehealth services when I worked in Philadelphia in academia. And so the transitioning now to a delivery system that is really depending a great deal on telehealth, I think it is a cost saving measure for clinics to be able to use telehealth to deliver services. And so I look forward to understanding how that can potentially improve rates over the course of time as the balance of healthcare delivery shifts into that less costly mode.
Appreciate those comments. Thanks, Dawn. All right, I think we're ready to move to the next piece. I don't know who's leading for Mercer. Is that you still, Sally? Go ahead.
Actually, it's going to be Emery.
Is it gonna be Emery? Okay, I couldn't remember what was
Yep.
next.
Thanks.
Yep.
So let's move to the next slide. So based on the information that Sally just provided, so where do we stand? So number one, the composite rate with all those plan design changes is now coming in at below 3.4%, which is the same as before, but a little bit better. So the surplus has grown from about 2 million up to about 5.4 million. Part of that reason is because of number 3, which is the Kaiser renewal. So the Kaiser has reduced the rate increase in total, although they are holding fast on that 13.5% increase for the HMO plan. What they ended up doing was reducing the deductible plan from that 13.5% increase down to 7%. And that essentially works out to about 1.2% decrease or $2.4 million over the entire Kaiser plan. So by doing this, the Kaiser deductible plan now does meet that 10% threshold in terms of the difference between the statewide plan and the Kaiser deductible, and thus becomes a low-cost plan for the non-OUS employees. In regards to the lowest cost plan for the OUS employees, we'll talk about that in a couple of slides where we show the contribution rates or the premium rates, and and some of the decisions being made today will also potentially impact what is the lowest cost plan for the OUS employees, and we'll go over that in a couple more slides. But for the low cost plans, as noted for Kaiser deductible, that now is a low cost plan. Providence Choice remains a low-cost plan, but MODA actually does not quite meet that 10% threshold. They're at 9.9%. So they're almost at a low-cost plan threshold, but based on the plan design options and that were voted in by the boards, hasn't quite reached that. So there probably will need to be board action on the MODA plan if you want to potentially subsidize that plan, essentially spend stabilization reserve to buy down the premiums to make it essentially a low-cost plan, for which it has been for the majority of the state employees for multiple years. So that's where we are on the plans right now. As mentioned, we have some plan design changes that we'll be going over in the following slides that will need to be voted on and will impact the rates. And then in June 20, yes, go ahead.
And I just wanted to make a comment. I do think that as a board, we've seen the lowest cost plan for OUS only impacts SEIU members. And I just want to caution us not to, I mean, it's going to land where it's going to land, and it's changed from year to year. So I just want to name that. In the 3 lowest cost plans have been very close in price. So I don't want us thinking about like which particular plan should be the lowest cost plan. I do think continuing to keep our eye on the lowest cost plans for all of the state workers, because that impacts everyone, is something that we should pay more attention to. So just wanted to name that.
Thanks, Siobhan. Yep. So in regards to the plan designs, that will be something be voted on today. Another thing to discuss potentially is to potentially increase, add a funding assessment to increase essentially the revenue to PEB to get to that 3.4% threshold. So actually, let's move on to the next slide. So as mentioned down below here, this is the composite rate. And so at the very bottom, you can see where you currently line up with the 24, with the preliminary, with all of the plan designs you've currently voted in so far, and the updated rates from Kaiser. So you're coming in at about 2.9% increase at $1,767.54. And that is the $5.4 million below the limitation. So if you wanted to increase, apply a funding assessment to increase the composite rate up to that 3.4% limitation, that's almost half a point. So it's about 0.482%. And so that's essentially the room you have to apply to the medical rates for the active employees to kind of get you to that 3.4%. I know there's some decisions that may increase the cost and would essentially eat into that funding assessment. And if you did spend money to buy down the MODA rates, that would essentially, it's your spending funding assessment for that, but then that would also bring down the composite rate, and then essentially you would increase the funding assessment to get to that 3.4%. So it's kind of just little mechanics, just kind of where you bring down one rate and you increase all of the other rates to kind of get to that 3.4%. But before we move on, I guess I just wanted to pause and see if anyone had any questions as to some of the possible movements that might happen with the composite rate. Let's move on. So the plan designs, the current rate increases you can see in the middle after all of the plan design changes and the Kaiser rate concession. So Providence statewide with the increase to the massage benefits now has a 4.3% rate increase, which was about 3.6% before. And so the premium rates did increase to about $371 million in total. Providence Choice with the Epicor reduction is now about 6.5%. That didn't really change too much. Kaiser and tolls at 12.3%, and then the MODA with the copay max did decrease a bit more, so it's now 5.6% increase. And then you can see the other plans which did not change. So overall, composite rate increases that 2.9 million or 2.9%, and the total projected premiums is just over $1.2 billion. The next slide shows the premiums. And so this is to Siobhan's point about the low cost plans where you have to be 10% below, 10% or more below the most widely available plan, which in this case is a statewide plan. So we show all of the plans here. So Kaiser HMO is coming in about 3% higher than statewide, and thus will not be a low-cost plan and hasn't been a low-cost plan. But the three plans to the right, the Kaiser Deductible, MODA, and Providence Choice plans have historically been low-cost plans. And as you can see, Kaiser Deductible is coming in at 10.8% below statewide. Providence Choice on the far right is coming at 10.9% below statewide. And so those are currently low-cost plans. But MODA, there in between the two, is coming in at 9.9%. And so what does that mean in terms of dollars for potentially buying down the rates to get to that 10% threshold? It's about $0.2 million. So it's not a significant amount of money, but it would have to be a board decision in order to get MODA down below that 10% threshold. And that would essentially put it exactly at 10% below statewide plan.
And Emery, just for clarification here, I know we're going to have a couple more decisions to make today that will impact rates. And I just want to clarify that in June, when we vote on the final rates, that we can also vote on the final if any of the plans need a small assessment from reserves. Is that right? We can have that vote in June.
You can have that vote in June, or you can have that vote now, and we can make that calculation to ensure that the rates, meet what's the board's intent. And then we can give you the exact numbers in June. So you can see the exact numbers in June based on all of the decisions, and then those exact premiums would then be voted in along with the fully loaded rates, the ones with the admin, the funding assessment and commissions and all the other additional costs on top of these premiums that we show.
Thank you.
So any questions on this? We'll provide additional details. We go through some of the plan design changes on the potential impacts to these premiums and that 10% threshold. Go ahead, Greg.
Trying to find my mute button. So has, and I'm sure they have, but I'm sure MODA has been made aware that if we don't, that they will move into the higher bracket. And are there potentials for them to look at this further, or is this where they're at?
Sorry, I didn't catch the second part of your.
If I'm understanding correctly, is this so the 9.9? Is there any movement on that, or is that solid where it's at before we make a decision? Put it that way, to be kind of plain.
That's solid. I mean, it's the rates that we're set. That Mercer has set for MODA based on all the plan options that PEBB has the board has currently voted on. So the copay max program did reduce the rates. We used their pricing assumption for that, at the savings assumption for that, and statewide did increase because of the massage benefits, slightly offset by the Epicor. And so we did not change any of the rating assumptions or the claims from the prior. We wanted to keep it, as justifiable as possible in this case, and it just came through that they're right on the cusp. But yes, MODA would be, I'm sure very well where they're not quite at the 10% threshold.
Right. I just wanted to make sure, because if If they don't and the board decides not to, which I'm saying neither one way or the other, then they would go into the upper rated plan, which contracts would be 5% instead of 1%, which may move some individuals, out of that.
Yes.
It does make a, there is some fallout there. So I'm just trying to get that all in my head. So thank you.
Yeah, and just
and
I just wanted to comment on that and underscore it, Greg. I think, as you know, we did a survey with our members recently, and SEIU members, just to be clear, with our members, and they're very sensitive to the premium. That's what they're most sensitive to, more sensitive to that, and then deductibles and co-pays. So just want to flag that as we're thinking through these decisions.
Yes. And there are like over 9,000 employees in the MOTA plan, and the majority of those would be impacted by the contribution differences going from 1% to 5%.
No, thank you very much.
Any other questions before we move on to the plan changes? Okay. So let's move on to the next section, and I believe Sally.
Yeah, I'm just going to jump in here briefly because I think then Andrew will jump in. But this is just, you've seen this already. These are the two self-funded plans. They're administrative fees. No change in either of them from the last board meeting. And we'll note that last board meeting was sort of the final round in terms of the fees, and MOTA did come down slightly on the basic admin, the utilization management, and the disease management. So which reduced those by from 2.9 down to 1.7% overall. And so that's all I have for that one. The next, I think now it's you, Andrew, I think, on the next one.
Yeah, thanks, Sally. And there are two additional items to be voted on today that could influence those administrative fees, one of which is this first item. But before I dive into that, I guess let me step back for a second and just sort of orient everyone to how these slides are set up. And so the way that we've organized this is to set up a summary slide for each of your three medical carriers. So this one is Providence, then we'll have MOTA and Kaiser. To sort of allow you to see side by side what are the remaining decisions that need to be made for these medical carriers. Some of these topics are a little bit more nuanced than others, and so we do have additional sort of support content later in the deck. And we've created these little hyperlinks in the far right comment, and so there'll be a little bit of sort of jumping back and forth. As we get into a topic with support slides, we'll get to those slides, we'll jump back and ask you to vote on these summary slides. And so we were thinking that we would have board members vote sort of topic by topic, just to make it a little bit easier to vote as opposed to voting on this entire slide, one item and then the next item and the next item. But obviously we're flexible there if you have a different preference.
I think that's right, Andrew, especially because there will be things that apply only to a particular carrier, and then we can vote on those, and then the ones that apply to all the carriers, we can talk about the supplemental information, for example, the anti-obesity medication. Go ahead, Ollie.
Oh, thank you. Just wanted to follow up on Greg's comment about MOTA earlier. I think it's important for the board before we get into these discussions to remember that these self-insured plans are your plans. They're the PEBB board's own plans. So when you're making decisions, you're at risk as you hire these carriers essentially as third-party administrators with their networks and all the administrative processes. So just wanted you to keep that in mind. Thank you.
No, appreciate that, Ollie. And it's why we have the stabilization fund, right, to carry the risk, because these are assumptions that are being made. So if the costs come in lower, then we save. And if they come in higher, then we pay for it through the reserves. Correct? Thanks.
Yes.
All right,
Also,
Andrew, back to you.
All right. Thank you. And so we, from here through the duration of our meeting today, we basically have 5 slides that we're going to ask you to vote on. And like Siobhan said, some of these topics apply to more than one carrier. And so, looking at the time, I think we're sitting well to get through these votes in the next hour and a half or so. And so with this first topic, this is around the RX Savings Solutions Program. This is one we've talked about over the last few months. And just as a sort of quick reminder, this is a voluntary program where Providence would be subcontracting with a third-party vendor, which is RX Savings Solutions. RX Savings Solutions would receive a data feed from the PBM to identify potential savings opportunities. When those opportunities are identified, they would then do a reach out to the member. Participation would be completely voluntary. Members can opt out of receiving those communications. We've sort of had additional conversation with different pharmacy resources at the carrier to sort of understand in a little bit more detail a few items. And we've changed our recommendation to decline this one based on two factors that have emerged in those conversations. The first of which is a taxable burden that's created with a certain type of incentive. And so one of the savings opportunities that RX Savings Solutions does is to identify members who are on a generic drug and perhaps there's a less expensive alternative generic drug available to them. It's really hard to, how do you convince a member to switch from one generic drug to another? There's no impact to them, right? They're paying their generic copay. And so in terms of influencing behavior, that is a little bit of a challenge. And so to get around that, what RX Savings Solutions does is they send a gift card as a $100 gift card, something like that, as a potential way to sort of incent those members to make that change. And so we've taken that back and worked with our compliance folks. We do think that is a taxable benefit, which would create a burden for PEBB. And there is the ability to turn that incentive component off within the program. But then you're going to potentially eat into what are sort of some modest savings in year one that are being projected anyways. And so that's one issue. And then the second issue that we've delved into more is around the performance guarantees around ROI for the savings that are being projected. And from Mercer's point of view, those PGs are really sort of inadequate. The way that those savings would be reconciled would be after 4 years with the program, which obviously is a long runway. And should it be determined that PG was not met, there's no cash that's returned to PEBB. You would just get a credit to sort of continue spending with the program. And so not really sort of significant teeth with those PGs. And so those two factors have made us revisit our recommendation on this one. Because this is a voluntary program, this isn't something that would be harmful for members in any way, but in terms of the value of implementing this, we think that it's sort of meager. So I'll pause there, see what comments board members or others have.
Thanks, Andrew, and appreciate Sean raising concerns around this in the last meeting. So this is one that we can make a decision on. We don't have another slide on this. If anyone would like to make a motion. We do have to make a decision on whether we accept or decline, so I'll need a motion on this.
This is Kimberly. I'll make a motion to decline adding the RX Savings Solution Program.
All right.
This is Andy. I second.
Great. Thank you both. All right, Dawn, how do you vote?
Approve the motion to decline given the modest savings, the administrative complexity, and inadequate performance guarantees. Thank you.
All right. Thanks, Dawn. Greg?
I agree.
All right, so you also are a yes to decline. I know Chicky had to step away. Chicky, are you back?
I am, and yes.
Great.
Yes, and I am in the same boat.
Okay.
Yes to declining.
Great. Approved to decline, and then Sean.
I vote yes on the motion.
All right, so it's unanimous. Thanks, everyone. I think we'll move to the anti-obesity medication exclusion. And I don't know if you just want to take us to the slide since this pertains to the more detailed slide, since it pertains to all of the plans, and we'll talk about it from there.
Yeah, I think that's a good idea. And this is one of our topics where we're probably going to want to carve out more time for discussion. And so if Maggie, if we can jump to slide 25, please. I mean, I'll sort of kick this off. We have Dr. Chuang on the Mercer team as well, who's going to chime in with some color commentary. But I'll get us started here. And so the recommendation that Mercer's making here is to defer the go-live date for opening up the formulary for these weight loss drugs until sometime in 2024, and to sort of roll it out mid-year. And so the rationale there is an attempt to sort of balance, what we know is a need that members have today, right? And we want to allow members to get the treatment that they need on the one hand, and sort of balancing that with the fact that this is a really complex and emerging and nuanced issue that we think warrants sort of a deeper dive analysis to really evaluate a few components that, if we collectively can evaluate those, we can more successfully roll out this program and create a more likelihood that members are going to be able to use this type of treatment successfully. And so, there are some existing issues that we think warrant a little bit of a closer look. And so some of those include choosing the right lifestyle support vendor. And so some of PEBB's subcontractors today offer solutions in that space. Virta and I believe Omada is standing one up. But there are a lot of other emerging carriers in that space. And the capabilities differ pretty widely. And so with Virta, for example, they don't do a drug tapering program. There are other vendors that do that. We don't have alignment amongst PEBB's medical carrier partners regarding what level of involvement these lifestyle support solution vendors would have is another issue. And so, Mercer's point of view is that requiring at a minimum sort of participation with one of these vendors would be a really critical component of prior auth, and we don't have alignment amongst the carriers with regards to that approach and that level of involvement from a lifestyle support vendor. Additionally, Moda has proposed potentially opening up the formulary to other weight loss drugs in addition to GLP-1. And so that's an area where it really requires a sort of deep dive analysis to understand, the appropriateness of that potential strategy. As we've talked about, Kaiser's stance today is that there isn't currently sufficient evidence to justify adding GLP-1s to the formulary for folks for weight loss who don't have a type 2 diabetes diagnosis. But that's something that they're looking at again for 1/125. And another analysis which is sort of underway today is with the Oregon Medicaid Pharmacy and Therapeutics group studying this exclusion as it relates to Medicaid. I think last I heard, we anticipate that analysis in the third quarter of the year, and so there's potentially an opportunity to incorporate the findings from that study into and sort of inform any potential PEBB strategy. And so there's the other thing I'll say, and then I'll pause. I see, Sean, you've got a comment. The other thing I'll say is that there are a lot of considerations around social determinants of health, particularly as it relates to requiring participation in a lifestyle support program. There's a lot to unpack there to really understand what vendors can do to help folks who are impacted by one of those social determinants. So, okay, that was a lot. There's a lot of text on the slides. I apologize for that, but I'll pause. Sean, I see you've got your hand raised.
Yeah, thanks. So first, let me just say, there's a lot of words on this slide, but they're good words, and I appreciate you going over them. Like this is very thorough, and well thought out. We've had a lot of discussion. So this is a good summary of kind of the long and short of it. As I recall, where we started with this way back at the beginning of this entire endeavor months ago was essentially the same thing, which is that Mercer was like, you all were like, yeah, the system's just kind of not ready for this. So we should study it. And as I recall, I think I was the one that was like, well, what if this, you know, some alternative, this and that. So if my recollection is correct, that I was the one that sort of kicked that off, let me be the one to say then that this makes sense to me. This slide, it doesn't seem like the system's ready. Like there needs to be some more time. It's not aligned, all these reasons here. So with that in mind, from my point of view, I'm ready to accept Mercer's recommendation here. And work with the CO to kind of evaluate next steps and let the system kind of get its feet underneath it around this. So that's where I am. You know, I'm having to make a motion, but maybe I'll pause for a minute and just kind of see if anyone else has any other comments. But that's where I am.
Yeah, I appreciate your comments, Sean. And I just wanted to invite Dawn to speak too, because Dawn, I know you are doing a deeper dive into this as well, and just, you know, from a clinical perspective, where we are with this.
Thank you, Siobhan. In my role as Medicaid medical director, the Medicaid review is underway to inform the Oregon Health Plan coverage decisions and considerations around these medicines. The evidence is fresh. They do seem to cause weight loss as long as you keep taking them. They're very costly, and we don't know whether the longer term implications will actually have the impact on decreasing cardiac and stroke type risk factors down the line. The evidence doesn't exist yet. We do have good reason to believe that it might go that way, but because they're so new, we don't know that. And that is part of the evidence analysis that is happening both through the Pharmacy and Therapeutics Committee study at Medicaid, and also I think through what we're calling CO. What does CO stand for? Sorry.
It is the Strategic Evidence and Outcomes Work Group. I think I got that right, and it's basically a work group that looks at sort of complex clinical topics like this one and sort of puts them under a microscope. Is sort of the intent of the work group
For OEB. And
Correct.
we get invited. Sometimes we get invited to join because it's like a joint thing occasionally, but it's really OEB's kind of like technical work group where they go deep into sort of like, you know, medical specific issues, whatever.
Yeah, it really informs the OEB board to make evidence-based decisions, and they do a lot of kind of deep dive work, similarly to the innovation work group, but more related around OEB-specific plan designs, and sometimes there are ones that impact PEBB that we can leverage the group. I think Greg and Andy were on one of the deep dives earlier this year.
Yeah.
Greg, did you want to comment too?
Yeah, all I was going to say is that I have sat on all of their meetings. I have sat on probably the last, now they canceled this last meeting, but I have sat on probably the last 5 of those meetings. And yes, there are, a lot of times they ask us kind of where we are, and it's interesting to hear, as Ollie said, it's a lot of these things have come up on their side, and they're looking at it just as deeply as we are. But yes, I do and have been on that. It's the first Tuesday of every week.
So I do. I just want to comment on this particular piece. I mean, I'm I'm in alignment as well in terms of what Sean was saying, and really appreciate the work looking into this. We know we have many PEB members who really want to see this as an option, and which is why we had the discussion around, was there any way to do this mid-year when we have more data and get the plans to align on how it's going to happen. And the piece around the rates, we know that there were rate increases associated with this, and my understanding is because we're coming in below the 3.4%, we would be able to use some of the stabilization fund to cover this with a mid-year plan change if this is the direction we vote to go. So just want to confirm that. And Ollie,
Yeah.
do you want to confirm that? Or sure, Emery, go ahead.
Sorry, don't mean to step in for you, Ollie. But yes, so this is as this is a decision that you would essentially be potentially be deferring until mid-year. We would not add it into the rates as they currently stand. You do have funds to help pay for this. You do have a surplus currently, and you have a surplus in terms of the year and as well as compared to your target. So there's additional funds there that could potentially be used to offset the cost, to pay for the cost of these drugs should the board decide to vote it in mid-year in 424. So it should not be a significant hit to the finances for PEB if you did want to say to defer it and then elect to cover at that time. Yeah, definitely. And we do have a timeline, a potential implementation timeline on the next slide if we want to go to it. But Dawn, you had a comment, question?
I just want to acknowledge the work that the work that Mercer and Dr. Chwing are doing to review the evidence, and I want to acknowledge the equity issues here with regard to the drivers and the social determinants. And I also want to express my concern around the rates using the stabilization fund, and I trust that you can go into better detail about that. Using the stabilization fund for this would function for 1 year for this service for this year, and it would use up the stabilization fund effectively, right? And then we will be looking at next year and where we're going from here. And I don't think I have a grasp of what the implications would be of that.
Sure. So actually, why don't we just go to the next slide for that, because we do make a reference to it here. So in terms of the work with the CL there in 23, talking about it and incorporating the Medicaid report there in the middle of the year, and then the findings would be determined in December or so, somewhere around that time frame. And then once those findings have been determined, whether they recommend to approve or not approve those drugs, it would be brought to the PEB board. Since CL is the first Tuesday, it could potentially be brought to the PEB board in December, that same month, and then you could hear the information and then vote on it either then or the following month. In terms of the rates, because that decision is so much later for a July implementation, and we wouldn't be incorporating it into the rates for 24 for the second half of the year. Yes, you would be using funds, essentially the stabilization fund or the funding assessment that you could be voting in to get you to the 3.4% to offset essentially most of the cost, essentially all of the cost of these weight loss drugs. We don't know exactly how many people are going to take it. Some of them might be actually using it for the diabetes, and then thus, would be potentially, there'd be just kind of like a shift, or, they're using it there. And so it wouldn't necessarily be all new utilizers in that case. But once that vote does come in, it would be prior to our rate setting for the 25 process. And so for 25, knowing that the PEB board has elected to cover these services, we would put it into the rates for 25 and beyond. So the hit in terms of the cost would be for 25, and you'd just be essentially funding it out of the reserves for the second half of 24. Does that help answer your question?
Yes, thank you. And I would hope that there would be cost savings in terms of improvements in health that would result from the decrease in weight, especially that first 5% that has such an implication for potential onset of diabetes and potentially preventing. Again, we don't have the evidence yet at this time. Sorry, Andy, I see that you have your hand up.
So I think my concern is that we're looking at these costs and, again, not knowing how long people would be on this medication. I'm concerned that it's going to be like they need to be on it long term, that these lifestyle changes may or may not happen. And that might be, if that, saves people's lives, that could be good, but that could be a really big cost long run. And so I do think, I understand supplementing it for, half a year and doing that, but I'm curious if we're going to end up having, not having it rolling. So if you have 5 people on it and they stay on it, it's not rotating out. So the new 5 people can come on it. Anyway, so that's kind of, again, we won't know for a few years, how that data will come out. But I do have quite a few concerns about trying to cover that and then end up having to increase rates, kind of like Dawn was saying.
Yeah, and the savings for some of the health improvements, they're not going to be immediate. They would happen avoided costs, which are softer. It's harder to do it, and hopefully the CIO and other studies will help show that and maybe prevent people from getting to type 2 diabetes. But go ahead.
The other comment I'll make there, Emery, is that Dr. Trang, you can keep me honest here, but I think that one of the activities the CIO, in preliminary conversations, the CIO work group has contemplated is sort of drawing up what a cohort analysis might look like to sort of study that very topic.
Yes, and this medication is already being utilized in the treatment of type 2 diabetes, of which a subgroup of those have the obesity as a comorbidity. So, think of them as being further downstream in terms of the cardiometabolic disease progression. So that's an opportunity while we are doing our research and cost benefit analysis, really understand what that uptake is and the lifestyle participation engagement rate, what's working and what's not, to be deliver a holistic human-centered approach to this.
Sean, you had the question?
I would like to make a motion that we accept Mercer's recommendation on this topic.
Do I have a second on the motion?
This is Andy. I will second.
Right. I will go ahead and move us to a vote unless there's any further comments on this. Greg, did you want to make a comment?
No, I was going to second.
Okay. Dawn, how do you vote?
Approve the recommendation.
Okay. Greg, how do you vote?
Yes.
Okay. Chicky?
Yes.
And Andy, you seconded. Kimberly?
Yes.
Okay. And Sean made the motion. All right. The motion passes. So again, we will be examining this in full because I just want to be clear, this does not mean we will definitely be adding the drugs in July of 2024. This gives us time to get more data. And then we should just have I appreciate Greg and Andy that you've been going to the CIO meetings. We can have a further discussion in June if we have additional folks who want to join those meetings to discuss this topic. But hopefully we have a lot more data by December and the plans are aligned, all the stars align. We'll see. And then we'll have further discussion about this in our December or January meeting. All right, appreciate this. I think we are going to move on to fertility. Do we have a slide on fertility, or do we just have it listed separately for the 3 plans?
We do, yeah. So
Okay.
if we want to jump to 32, Maggie, I can kick us off here. I do have one of my colleagues, Brittany Bono, who's from our total health management practice, who really is an expert in this area. But I'll sort of open it up, and then she can provide color commentary. And so this issue, as well as facial electrolysis, which we'll get to next, are member feedback driven potential enhancements. And so just to sort of remind folks, what was sort of the genesis of this particular issue, there was member feedback submitted regarding sort of the inadequacy of the pharmacy benefit for fertility. And so as you might recall, there's a $10,000 pharmacy benefit for fertility, annual benefit, for both Kaiser and Providence, as well as a $25,000 medical benefit. MODA combines those, and so there's a $35,000 combined benefit with MODA. And so the feedback from this member was that you know, the pharmacy benefit really was inadequate for the treatment that she was undergoing. And so as we sort of started researching this option, this issue, one of the things that became readily apparent to us was that the members don't get the advantage of, don't get the credit of any rebates that are applied to these fertility drugs. And so when they're actually at the pharmacy at point of sale, they're paying the higher cost, which is more quickly using up that $10,000 pharmacy benefit. And so we spent, and so that's really the focus. I'll back up a little bit. That's the focus of today's vote. Sort of separately, we have gone through a really sort of detailed deep dive analysis where we look at, it's a gap analysis where we look at potential differences between the carriers with regards to how they're administering fertility benefits, as well as some sort of recommendations and considerations. And so that detailed report is something that will come at a later date. And so really today, what we're asking you to vote on will be a couple of enhancements, which we think will address this pharmacy issue that's come to light. And so if we want to jump to the next slide, this is the, just wait for that to flip over. Thank you. This is the slide where we've identified two options to help address this issue. And we did also separately, we did explore with the carriers potential manual workarounds to apply rebates at point of sale to allow that $10,000 benefit to go a little bit further. But you know, in sort of discussing that with the carriers, that would be a heavily manual process and sort of clunky. And so option one, where we're recommending just remove the $10,000 pharmacy limit altogether, is a simpler solution. It's not a huge additional cost. And if you look at the utilization of this benefit in 2022, it's really the pharmacy maximum that folks are hitting. They're not really hitting the medical maximum. And so to get rid of this pharmacy maximum is going to be a really nice enhancement for those folks who are wanting to use these services. And it sort of eliminates this issue where, you know, due to the fact that there's a benefit cap, this lack of credit for rebates is really sort of driving a meaningful impact for these members when they're at the pharmacy trying to get these drugs. Yes.
I just have a question here. If you could provide an explanation why the MODA amount is so much higher than the other plans. Just be helpful in understanding that, and it's something we have to pay attention to because of the premiums.
Yeah, and I don't know if Brittany, you have any comments regarding that or not. I think these were estimates that we requested directly from the carriers, and so you know, Brittany, if you have comments, great. If not, you know, maybe we can open it up to MODA as well. But Brittany, did you have any thoughts?
The only thing that that I would say is that based on historical utilization, there were a good number more members utilizing the fertility benefit through MODA compared to Providence. I know some changes were made in 2022, and so we may continue to see those numbers shift a little bit. But just looking back at 2022, the MODA plan saw 350 unique members using the benefit, whereas Providence saw 81 members using the benefit. So I assume, you know, that they were looking at that utilization when creating their projections.
That's helpful. Thank you. So given this, do I have a motion around this, or is there further discussion questions that folks have? Dawn, go ahead.
This is Dawn. Is that a matter of network adequacy? Are people going to MODA for this reason? That's a huge difference.
It's a good question.
think
I
that's-
don't know if it.
Yeah, I think that's something we could follow up with the board in 6 months, say when we have a little bit more data and take a look back and see. You know, right now we're working on very little time frame. So that is surprising though. Totally agree.
I mean, one of the things I just want to make a comment around this is that we know that we had a lot of PEB members waiting for the benefit. The benefit is now here. We know people's, clocks are ticking when they're waiting for access to IVF. And we know that the plans have handled it a little bit differently based on what drugs are covered, how rebates are applied. And when we initially voted in this benefit, we talked about how we may have to revisit because we weren't really sure how we set it up, whether that would be the right way to set it up. So I just want to name that as we think about this and having a benefit that folks really are able to utilize and not be so limited in terms of how it was initially set up.
Thank you.
All right, so do we have a motion on the fertility coverage? This is something we'll need to make a decision around. Greg, go ahead.
Yeah, I make a motion that we do take the emergency recommendation option.
So I'm having a little trouble hearing you, Greg. Could you restate it?
Sorry. Is that a little better?
Yes.
Okay. I make a motion that we accept Mercer's recommendation with option 1.
All right, thank you, Greg. Do I have a second?
This is Kimberly. I'll second the motion to accept option 1 as
All right.
presented by Mercer.
Thank you, Kimberly. Dawn, how do you vote?
I'll vote to approve the
All right,
recommendation.
Thank you, Dawn. Chicky.
I vote to approve as well.
All right, thank you. Andy?
I vote to approve.
Great, thank you. And Sean?
Approve.
Right, the motion passes. All right, thank you. So we're going with option 1. And I think we're going to move on to facial electrolysis, correct?
Yes, wonderful, thank you. And so for this one, Maggie, I think you are going to be taking us through this one starting on slide 34.
Yeah, thanks, Andrew. Good morning, everyone. As Andrew previewed, this topic came up via member feedback and an inquiry. And the ask was whether PEBB would consider facial electrolysis for members experiencing hirsutism, which is male pattern hair growth, typically due to elevated androgen levels. In the particular member's case, it was related to PCOS, which is polycystic ovarian syndrome. And so one of the things that we did in this is we took it to the health equity work group to analyze whether there are health equity impacts of excluding coverage for folks who are not undergoing gender affirming care. So in PEBB's benefits, it's covered facial electrolysis for facial hair is covered for members undergoing gender affirming care. So when they're transitioning from male to female. However, it's currently excluded for anyone else, and it's deemed cosmetic in those situations. So what we did is we considered that, PCOS and hirsutism disproportionately impacts women or people who choose to present as female. Because of that, we wanted to figure out whether the carriers would be willing to administer the benefit should PEBB choose to accept or decide to cover it. So on our next slide, what we did is we summarized the carriers' positions. So currently all 3 carriers limit the coverage to gender affirming care. They don't have other clients in their books of business that cover it for reasons outside of gender affirming care. And then we asked them what their positions were. So Providence and Kaiser felt that at this time, it's not medically necessary for members with PCOS or hirsutism. MODA did feel like there could be a case made for it to be medically necessary. And so we worked with the carriers and found out that both Providence and MODA would be able to expand the benefit to cover facial electrolysis for members who have PCOS and hirsutism. Kaiser is not able to do that at this time. So you'll notice that we have estimated a cost impact here. We received the news from Kaiser that they have not been able to receive an exception to allow this benefit. So at this time, that would now be $0. But for the other two carriers, it's an approximate $250,000 annual impact should the members who have both these conditions choose to seek care. So I guess at this point, the health equity work group did feel like it was worth moving this forward and bringing this to the board for a decision. And so that's kind of the information that I have for you. But if you have questions or comments, feel free to chime in.
I just have a question. Is that something Kaiser can continue to examine, since clearly they offer it for folks who have gender affirming care?
Safari or Troy, would you mind jumping in? Don't know if Troy is on. Or Dr. Bachman.
It's something we can look at. I mean, we have processes in place related for gender-based care, so we certainly could use similar processes and contracts for this if necessary. We'll be really defining what the guidelines are for it.
Okay, thank you. I know I was not able to participate in the last health equity meeting. Sean, I don't know if you were able to participate. It certainly shows up as a health equity issue. And I don't know if anyone else wants to comment on this before we move to a vote. Andy, go ahead.
I just want to, I believe it is a health equity issue. And I think that it is important that we look at other conditions that make people feel like they're part of their own gender, right? So I do think this is an important issue, and we need to look at it holistically for all people.
Thanks for your comments. All right, so do I have a motion on this?
Could you clarify what we are moving to do?
Oh, yes. So is that on the next slide? The motion would be, well, what the recommendation is that we add facial electrolysis to the plans as a covered benefit.
Particularly, I think we're specifying that this would be for members who have diagnoses of PCOS and hirsutism in conjunction.
That's right. Thanks for that clarification. And I'm looking at the slides. I don't think you have the slide that names that, but you do when you go back to the Providence and MODA slides. Dawn, go ahead.
If the hirsutism is causing the health equity issue for people presenting as female, assigned female at birth or not, then why are we limiting ourselves to PCOS related hirsutism in our coverage? Medically necessary being the question that we need to answer. It seems like the driver is the hirsutism itself.
Was that discussed at the health equity work group? Go ahead, Maggie.
Yeah, it was. So we discussed it a bit with Tom Siltabo, who is the physician and a board member for OEB. And we landed on PCOS and hirsutism just because of the complexity of the various conditions that are aligned with hirsutism. But I think we could certainly open it up to, removing having that conjoining diagnosis of PCOS if needed. I just think that we may need to have some medical professionals gather to determine what those criteria would be. I don't think that that's something that necessarily the Mercer folks, other than Dr. Twain, could weigh in on.
Thank you.
Yeah.
It seems like a reasonable subset. The PCOS causes hirsutism. That imbalance of hormones drives all of that.
It is the largest group that is associated with medically or clinical reason of hirsutism.
Right. I'm noting Keith Bachman, is that Dr. Bachman, making observations in the chat.
So my question here is, because, you're bringing up an important point, Dawn, and I know we're also up against the time, our time crunch in terms of making decisions for this next plan year. Is this something that we can continue to get more information about, even if we just open it up to PCOS now and potentially make it broader for the next plan year? Just some direction in terms of where we can go today would be helpful.
Yeah, I think, Siobhan, that similar to the fertility benefit change, I think this is something that we would bring back to the board for further discussion when we have some additional data and revisit for the next plan year. We can make that part of the request letter to the carriers for the next renewal.
Okay, so for now, it sounds like where the recommendation is it's limited to the, and excuse me if I say this incorrectly, the PCOS hirsutism, correct? That's what we're looking
Yes.
at. All right. So, so that's where we are today, and then we can further examine for the future. Is there a motion to expand the facial electrolysis for folks with PCOS hirsutism? Sean, go ahead.
So moved.
All right, Sean has made a motion. Do I have a second?
This is Kimberly. I'll make a second.
All right, thank you, Kimberly. All right, Dawn, how do you vote?
I'll vote to approve with the caveat that I'll look forward to a more a better understanding of the clinical criteria and how we're moving ahead, what the trajectory looks like. I do agree that it's an equity issue.
Appreciate that. Thanks, Dawn. Greg, how do you vote?
I approve.
Thank you, Greg. Chicky, how do you vote?
I approve as well.
Thank you. Andy, how do you vote?
I approve and I support Dawn's comments.
All right, thanks everyone. So this motion passes. All right, I think we're moving on to the MODA slide.
Yes. Okay, thanks, Maggie. We've already talked about 3 of the topics on this slide, and so that really leaves us with the first 2 rows, which are sort of combined topic. We've been talking over the last few months around MODA's proposed Behavioral Health 360 program. And then, as the discussion evolved, we started to look at potentially offering a Spring Health standalone solution as an alternative. And so I'm going to hand it over to my colleague, Christy Ewing, from our Behavioral Health and Health Equity team, who's going to take us through some of the considerations there. If we want to, Maggie, go ahead and jump to slide 30, please.
Great, thanks, Andrew. Good morning, everybody. So as we, as Andrew shared, we have talked about this, the MODA BH 360 program a couple times. In our last deep dive, we've looked now at Spring Health standalone. And so just to share a recap of the program. And so this is MODA's, responding to the board's request for faster access recognizing that there is such a need for behavioral health care. And so we do value that this program is that response. What we have found with the data that's been provided, because this program is in place for other members, not the PEB membership, but the value really that's being shown is through the Spring Health provider network. And a couple of reasons for that is that Spring Health has the capabilities, digital access, and 100% of their licensed providers have their schedules available online and have their appointment capacity. So they can guarantee less than 2 days access to an appointment. They also measure time to third appointment, which is another crucial piece that a lot of times first day appointments don't meet the members' scheduling needs. And so a lot of times looking at that third day to appointment. So they consistently show that they are providing huge value with fast access to quality behavioral health care. The additional component of the Behavioral Health Champions program really is the champions, which is the person who is trained answering the phone. They are not licensed, but they do have, training in navigating and supporting folks through behavioral health. And while we recognize that this is a value add for some members, it's basically a telephonic person that they can contact. But that given that the fees are already high for PEB in relation to other carriers, and then also that the MODA 360 program already has an add-on PEPM, which is including the MODA 360 navigation support. Our recommendation is to decline the MODA BH 360 program and to instead implement Spring Health on a standalone. On the bottom of this page, we've kind of called out some of the different capabilities. And so I'm going to quickly just kind of talk through those. So each program has kind of what is a navigator. It's a person designed to help a member navigate through behavioral health, which we know can be complicated and people can be in times of crisis. And so both programs do have that. The MODA BH 360 is, mostly a telephonic person navigator that can help people get connected to Spring Health, get connected to the other two subcontractor programs, which is Gemini for autism spectrum support. And then the other one is some Hazelden Betty Ford, which is a substance use disorder program, and it's their additional supports. Spring Health standalone does also have care navigators. Spring Health is primarily digital is their number one mode of access. Like that's how most people access Spring Health, but they do have care navigators and a telephonic phone line that people can call into to get support and talk to somebody. So both programs have that. The online scheduling piece, so 100% of Spring Health providers are on their platform with capacity, showing their scheduling, what's available. And MODA does not have that in place right now for their traditional provider network. Measuring provider quality, the third piece there. So Spring Health has proven through their Candela, it's a program they have for their providers where they do reward on outcomes. They have outcome informed care. They do have providers that are ranked based on how they are using evidence-based quality treatment, and also how they're showing that through clinically validated assessments that people engaging in their care are getting better over time. MODA is working on that from our understanding of the responses given. It's just not quite at the level that Spring Health is able to have it at and being able to provide reporting back to show improvement over time and what those provider quality metrics are. You can see here the average time to first appointment. Member follow-up, both of them have different modes of member follow-up. Again, I would say MODA BH 360 is a lot of times it's a telephonic follow-up. Spring Health is going to be more of a digital follow-up. And then they do have measures in place. So if somebody was to complete a clinically validated assessment and they would say any comments or indications of self-harm or suicidal ideation, then that's going to be a trigger in their system for a care navigator to immediately reach out to that person. You can see here we've, mode of initial access. Again, the behavioral health champions is going to be telephonic. Spring Health is primarily digital, but again, they do have that telephonic option. So as long as a phone number is being provided, then that option is there. And then the last thing on the table is just for the Real D provider search capability, Spring Health does have a very, very diverse provider network. And as somebody is walking through the network and looking to schedule with a provider, they can see pictures of the provider, they can read their bios, and they can see different areas of, again, with the Real D designations, as well as other competencies as far as their clinical needs, or different population communities such as LGBTQ plus IA. And so I'm going to pause and see if there's any questions.
All right, well, thank you for the summary. I think it might be helpful if you go back to slide 23 so we can make a decision around this. And I do want to recognize, the conversation last time, and in part the question coming up, why isn't this just part of what we're already getting from MODA? And, just want to recognize that mental health is, folks accessing mental health providers is something we're seeing as a challenge across the board with our carriers. So just want to name those two things and see if anyone would like to make a motion or has comments.
Siobhan, I have one additional comment that I left out. Sorry. I just wanted to also state that the Behavioral Health Champions Program pricing is a PEPM, so across the PEBB membership, whereas the Springs Health Standalone is only based on active users. So there's just a per active user cost on a monthly basis for folks that are engaged in the program. So paying more for what's being used versus a PEPM for the whole population.
Thanks for that clarification.
Mm-hmm.
This is Dawn. I appreciate the expansion. It looks like a considerable expansion of the network. Does that mean that the members still have access to all the behavioral health providers who are contracted with MODA? They still have access to that network. They just don't have the Behavioral Health 360 sort of navigation solution in place to facilitate accessing it. And we would shift to the Spring Health, which would add on the rest of this other network plus the Spring Health navigation solution.
That's right. The one provider that I'll call out that would be an expanded sort of network provider would be Gemini. And so meaning that if the board approved the Champions program, Gemini would be added to the network. And if the Spring standalone option is approved, then Gemini would not be added to the network. Gemini is, they provide autism spectrum disorder support. I think that, I don't know, Christy, if you have the utilization in front of you, but when we looked at it for OAB, it was very low. I think there were maybe 3 visits, if I'm remembering right.
That is correct. That's what's been reported is 3 visits.
Yeah. So Don, to the broader network piece that I think you're referring to, that would remain unchanged. So all of those behavioral health providers in the MODA network today, those will continue. Yeah.
Thank you. I move to accept the recommendation.
All right, so we have a motion to accept Spring Health as a standalone. Do we have a second?
Yes, I'll second if you can hear me.
Yeah, thanks, Greg. So Chicky, how do you vote?
I vote yes.
Thank you. Andy?
I approve.
Thank you. Kimberly?
Yes.
Thank you. And Sean?
Approve.
All right, thanks everyone. So I believe we're moving to Kaiser now.
Right. So I can kick us off here. We do have some additional slides here. Emery at the outset talked about what Kaiser's revised position is with the reduction to the rates on the deductible plan. And so you can see that there in the second column from the right, that 13.5 went down to 12.3% in aggregate, which represents a $24.5 million increase over 2023 costs. We do have some plan design changes that we reviewed with you all last month. We do have one slightly adjusted option based on last month's discussion, which is sort of a pharmacy copay change that is not as large of a change. And so if we want to go ahead and jump to that slide, please, which I think is 30. Well, I guess we can start on 36. Yeah. And so this, there's a lot of these bullets are things that we've talked about regarding the trend that Kaiser's using in their underwriting projection. And so that's a recap here, more so than us showing you new information. We do have their revised position there with the first bullet. And so, we are on our end recommending an increase to the emergency room copays for both plans. It's not a meaningful cost savings driver necessarily. But it would bring alignment with the other carriers, and it is sort of good, sort of just general plan maintenance. And if we want to flip to slide 37, that would be a more palatable change for PEB members enrolled in Kaiser than some of these other options. Siobhan had mentioned that the SEIU survey that was conducted, premium changes being sort of the most painful for folks to be able to deal with. And so, pharmacy copays are another, I think, Siobhan, you keep me honest, was another item that was a little bit on towards the end of the spectrum that would be difficult for PEB members to absorb. And their preference would be other types of changes like the ER copay change.
Yes, there was a split between the prescription drug copays being harder for folks and the ER and the doctor's visit copays not being as challenging when we ask people to rank them.
Yeah, thank you, Siobhan. And so, with the ER copay change, which we've got highlighted in that light blue color in that second column from the left, these are copays that apply for emergency visits that are coded as not true emergencies. And so this wouldn't apply to everybody who's going to the emergency room. As you can see, the rate impact is somewhat minimal, between 0.1% to 0.2%. If you compare that to the pharmacy copay change, second column from the right, those changes are getting you a full point. And so those are much more meaningful cost reductions. But again, that comes with the challenge that, that's more difficult for PEB members to deal with, and sort of more painful in that sense. But that said, the devil's advocate, I suppose, to that would be, the changing pharmacy copays are still very competitive in the grand scheme of things. I know that change is hard, but I think there's an argument to be made that, maybe the board might want to look at both changes potentially. Another argument is that you could just look at ER copays and save the pharmacy in your back pocket for next year. So there's sort of different ways to approach some of these plan design changes. So I guess I'll pause there and see what comments folks have.
Go ahead, Andy.
I think the ER copay, I think that's reasonable because it puts us in line with the other carriers. I think it's probably not the best time to do that. And the prescription copay, I think, people who have multiple medications and especially families who have multiple, that could be a lot of money all of a sudden. So I think it's maybe better to put in the back pocket for next year, and maybe even kind of give a hint to people that, hey, this is a great deal, but it's probably going to increase. Anyway, that's just my opinion.
Thanks, Andy. And I just also want to note, we have the ability to make a change to one plan and not the other plan, the HMO plan. For example, we could just do the ER copays for the HMO plan and not the deductible plan, correct? Just want to, because we have the rates listed here.
Correct.
Any other comments on this? Go ahead, Dawn.
I appreciate that the alignment of the ER copays, ER visits for potentially avoidable visits are something we want to disincentivize anyway. So you'll go if you need it and not if you can get what you need by accessing outpatient care. So that is in alignment with good clinical care and good and equity. Also, the increase of the increase of the prescription copays, I feel like has some equity implications. People who are bearing disproportionate burden of disease, especially chronic disease, those chronic diseases that require medications, those fall along lines that are in great measure driven by social determinants. And so that an increase in that copay is something that I want us to take under very, very advisedly, if we will.
Thanks, Dawn. Appreciate that. Any other comments? All right, do we have a motion around this?
This is Andy. Oh, go ahead, Dawn.
Andy.
Oh, no, I'll second. You go for it.
All right, I'll move to accept Mercer's recommendation to increase the emergency department copay on both plans.
All right, thank you, Dawn. Andy.
I will second.
All right, thank you. All right, we've got a motion. Greg, how do you vote?
I agree.
All right, thanks, Greg. Chicky.
I agree.
All right, thank you. And Kimberly.
Yes.
All right, thank you. And Sean.
Yes.
All right, thank you. I believe that was it for Kaiser, correct?
Correct. Yeah. So we are looking pretty good from a timing perspective. I think we have until 11:45, if I'm remembering correctly. So that should be plenty of time for us to get through these next couple of slides. We do have some additional votes that we are going to ask the board to make. And the first of which is around spending accounts and COBRA administration. And I think, Sally, for this one, I'll hand it over to you.
Okay, thank you. So we initially reviewed both of these programs, I think back in January. These were round one renewals. I wanted to bring them back because it does require a board decision to go forward with the renewals. So we have both ASI Flex, which is the administrator of your spending accounts, and then Benefit Help Solutions, which is COBRA and the Retiree Premium Administration. Both vendors are not requesting any increases in their fees. And so we're recommending to accept as is. So that's all I have to say about it. Yeah, keep it brief.
Thank you. So do I have a motion to accept these rate holds?
I can make a motion to accept the written.
All right, great. Thanks, Greg. Do I have a second?
Seconded.
Sean, you were our second. Did I have a question? Okay. Dawn, how do you vote?
Approve.
All right, thank you. Chicky.
I approve. Thank you.
Thank you. Andy.
I approve.
All right, thank you. And Kimberly.
Approve.
All right, motion passes. Thank you. All right, now we're on WebMD, I believe.
Mm-hmm. So this slide is just, it's the same slide we've gone over in prior meetings, providing an overview of their services, the purpose of their services. And then if we move to the next slide, so we've had some updated reporting around performance guarantees, and they did miss performance guarantees across all three carriers in 2022. And so listed are the penalties below that they will be paying. You'll see on Providence and MODA, they've missed both the reporting and the registration performance measures. And on Kaiser, it was the registration. So just for some perspective on the plan performance, and I don't know if Margaret is on the call and wants to make any kind of comment on this before we move to the updated financial proposal.
I am here, Sally. I don't know that I have a whole lot of comment, just a clarification. With regard to the reporting PG, that was just it was related to timeliness. So specifically having required reporting by a specified time frame. And so the timeliness factor is what caused the penalty. On the registration factor, that was due to targets they had for the percentage of eligible employees that would register for the program and falling short of that registration target.
Thank you, Margaret. So if we go to the next slide, we do have updated financial proposals from WebMD. So when we met before, we showed you the original renewal, which was the 25 cents per eligible member per month, with an estimated cost of about $304,000 annually for almost 103,000 eligible members. We went back and asked them, WebMD, to provide some additional options and to provide options to look at potential just based on utilization rather than across the membership. So the first option they provided was a reduced fee down from 25 cents to 20 cents per member. So that reduced the cost to $247,000 annually. Option 2 was based on utilization, so a $10 annual fee based on registered members, plus a monthly administrative fee of $15,000. And so we estimate that cost, the registration fee based on estimated number of registrants, at least historically 758, would be $75.80, and then the annual administrative fee would be $180,000 for a little over $187,000 annually under option 2. And so then after we received options 1 and 2, we made an additional request of WebMD and asked about a potential flat fee. And what they offered is what we have under option 3 and is what we were recommending, which is they came back with a flat fee of $150,000 annually, which would be allocated across the way it is currently across the carriers based on membership. All the options include the same services. So they include the WebMD One platform, designated account manager, account team support, one dedicated full-time well-being program manager, data hosting, data processing, customer support. So do we have any questions?
Yeah, just a couple clarifications. So is the fee 150 in my understanding, right? You don't mean 150 times 3, in other words, per carrier. You mean 150,000 divided by 3, or proportionate anyway. Is that right?
Correct. Yeah.
Okay.
Yeah.
Okay.
It's one lot. Yeah. It's just 150,000. So they've cut their original renewal proposal by about half.
Okay. Thank you. That was what I was understanding. I was just double checking. Okay. And so part of the purpose of the attaching a fee per use is like there's a incentive for them to like maximize their outreach and like effectiveness. In this kind of flat fee situation, what is there in place, I guess, briefly, to encourage action and just like technically it's available, and then they kind of sit back and like collect $150,000. You know what I'm saying? But it's like, what mechanisms are in place in order to like ensure performance, I guess is what I'm saying.
Yeah, Sean.
Oh, go ahead.
Go ahead, Sally. Yeah, go ahead, and then I'll jump in.
Okay. I was just going to say they have allocated a full-time well-being program manager, and really it's her job to work with PEB staff on ways to outreach and engage with the PEB members. So I think that's one of the ways that we'd be assured that they would continue the outreach and not just take the 150,000. But Andrew, do you have more to add?
Yeah, I do. Yeah. I agree with those comments, Sally. But you know, strictly from like a revenue perspective, they don't have that incentive today to really drive engagement. I mean, that well-being program manager certainly should be doing that. But to the extent that someone in that role can drive registration on the platform is a little bit tenuous from our perspective. And so we sort of struggled with this recommendation a little bit, and I'll sort of walk you through why. So it's great to see the reduction. You know, 50% reduction in fees is great, but even with that reduction, utilization is very low. And so, you know, I think there could be an argument made to, you know, renew it and evaluate if you want to continue with this program at all 1/1/25, and maybe have a group like PMAC look at it a little bit more closely from a member impact perspective. But you know, the way that this fee is structured today, Sean, you're right, doesn't really incent the vendor to drive engagement.
Yeah. So I would be interested in understanding the effectiveness and the efficacy of the program in some kind of formal way. Because if we're having like a mild effect on a handful of people, then $150,000 is pretty steep for that, right? So even though it's a lot less than what it was, in comparison to what you're getting, like it may still be extremely steep. So that would be good to know. I'm just planting that seed, I guess, as a request that I kind of want to reevaluate the situation, and I want to have some data to just be like, what is the impact of this, offering this? Like, if very few people are using it at all, and the way that they're using it could be done elsewhere for no cost, basically. That would be good to know. So I'm willing to support the recommendation for the moment, with the understanding that I really want to understand what this program's actually doing. Yeah.
So I just want to you know, build on the idea that we could make a recommendation to accept option 3 and send this program to PMAC for evaluation. Just want to double check with Ali or if Brian's on the call, if that's an option. Ali?
Yeah, it's definitely an option. And yeah, I can run it by Brian. I'm sure they could fit it into their.
Yeah, this is Brian, and of course I'd
Oh.
stepped away for a minute. So what was the specific question on the costs?
So it's not about cost, it's about you know, whether we want to make a recommendation, Brian, to go with option 3 here, which is on the slide, and send this program to PMAC for further evaluation, so we actually have some data on the efficacy.
Gotcha. And so the question is whether it can go through that process in time for the actual beginning of next year.
No, for 2025, because if we make the vote today to fund it, we would then make a decision in 2025 if we didn't want to continue with the program based on the data. That's my understanding.
Okay, I think that should be okay. I don't see why we couldn't take it through PMAC. Yeah, I think that should work, and we'll probably have Mercer help facilitate that conversation with them.
Yeah,
and Don, oh, go ahead, Sean.
I'm not asking for like it's $150,000. So on some level, you could spend $150,000 of PEBB staff time. We're like figuring out what the impact of the $150,000 is. So I'm asking, you know, be proportionate, but I'm saying I would like some formal look at like how impactful really is this? And that's what I'm asking. And if PMAC can help us do that, that would be great.
And so for
And-
PMAC, it would be from the member perspective, not Mercer would bring kind of the evidence to bear,
Yeah.
but really PMAC would speak to that member experience.
Yeah, helping sort out the evidence with member experience. Yeah.
Okay, what would be the requested kind of turnaround time or kind of target?
I don't know, a couple of weeks, I guess. No, I'm kidding. The I mean, presumably we would want to have a good understanding of the effectiveness. No, it's not just the effectiveness, it's the efficacy of this. At the beginning of next year's renewals, right? So so that we're not in the same situation next year where we're like, gosh, I wish we knew how effective this was.
So it sounds like based on our just annual renewal process, the goal would be then to be able to have hand off or inform Mercer of the PMAC feedback and potentially the Health Equity Committee based on our processes.
Yes.
And if we could wrap that up by the fall, that means we can, if there's any follow-up, we can make sure that that information is included on those first round one renewal letters at the beginning of the year.
Yeah.
Okay. Yeah, that sounds completely doable. Sorry for the 50 questions.
No, I appreciate you being very specific.
All right, thanks. Dawn, go ahead.
I gotta appreciate Sean Parkman again. Thank you, Sean. Are there so two things, both related. One is, are there not still performance guarantees to ensure some number of registered members and some kind of utilization and reporting? That's one. And the other is, what are the stated objectives of this program compared to the some of the responsibilities that the rest of our contractors, vendors have. And I don't need to hold up this vote for those things, although the performance guarantee seems to me like it might address some of Sean's stated concern of $150,000 flat fee doesn't incent registration and outreach and engagement.
Yeah, and so my understanding is that yes, those PGs do continue into the future. Maybe I think maybe what you're alluding to, if I'm understanding correctly, is can those be revised for the upcoming plan year? Because if we look at slide 41, the penalties that are being paid for not hitting the registration that's required in the guarantee, it's not super meaningful relative to $150,000, and so I know, Margaret, you're really closely involved when it comes to sort of that PG work, so I welcome your thoughts, but it sounds like is that, Dawn, what you're suggesting to sort of revise what those PGs might look like?
Right now, I'm not working with very much information, so I don't know what the best answer is, what we were expecting, what was achieved, what the outcomes are that are of interest. So I'm not in a position to advise on what it should be, but it sounds like those who are in a position to know that probably could tell us.
Yeah, well, and so right now the PGs are structured as a percentage of total fees paid. So if the total fees paid are significantly reduced from the current contract and that percentage is not modified, the dollar amount is going to proportionally go down. So I think that, is certainly something we can further discuss with WebMD. I mean, the PGs as they stand, it's a few, there are multiple PGs throughout the contract, and on the registration one in particular, it's a few percent of total fees paid tied to hitting a registration target, and that target was missed. So I think that the pieces we can work with, I think, frankly, some of the PGs probably are more meaningful than others. So if we really want to focus on our registration numbers, the conversation to have would be around revisiting what that registration target is, and whether we want to modify that, and then what the percentage of fees at risk tied to that target is, and whether we want to make any modification to that. So I think that's definitely something we can take back. Looking to Andrew and Sally, my understanding of this proposal from WebMD for the $150,000 flat fee kind of assumes status quo PGs, if I'm correct. So I think the discussion we would want to have is whether there's further room to update some of those PGs.
That's correct, Margaret. Yep.
And as I said, maybe reduce the number of PGs to really just have the ones we believe to be most meaningful and to have the higher percentage of fees at risk on those.
That sounds
Right.
good.
So thank you for the discussion around this. Do I have a motion? And again, we have to make some kind of decision here, so.
Yes, I mean, I'll make a motion. I'll make a motion that we accept Mercer's recommendation here on the slide, and that we refer to the PBAC committee for the and PEB staff for the purposes of evaluating efficacy and recommendations for next year.
All right, thank you, Sean. Do I have a second on Sean's motion?
This is Kimberly. I'll second that.
All right, thank you, Kimberly. All right, Dawn, how do you vote?
Approve.
Thanks, Dawn. Greg?
I approve.
Chicky?
I approve.
Right, and Andy?
Approve.
All right, thanks, everyone. So that motion passes. So I know that that was the last action required in our packet. I just want to go back to the conversation we had at the beginning before we close out our renewals. Do we need to have the vote today around MODA being a lower cost plan remaining in that status? Or is that something, Emery, I mean, and I don't know if, I know you have to calculate numbers. It's going to take a little bit of time to know exactly what that would look like. Or can we have that vote in June?
We can have that vote in June. So actually, let's move to the next slide. So we could have that vote in June. We have the plan design options that the PEB board has voted on, and we will create the premium rates and ask Kaiser for the updated premium rates based on the ER copay to get to the final composite rate before any sort of funding assessment. And based on the board's potential interest, we can also provide rates for MODA, which would include that buy down to reach that 10% threshold compared to statewide plan, and the impact of that on the composite rate, as well as the needed funds to get to a 3.4% threshold. So we can definitely, I guess, defer that decision until next month. I guess I just want to make sure, that I'm not potentially misstating or misunderstanding what the board is asking for, at least in preparation for next month.
So I believe it's important for us to have that discussion around MODA. We know that premium share, especially when the plans are very close to one another, we do have the flexibility of the board to make a decision around making sure that that lower cost plan is met. And I think we should have a discussion around it. And I really think that if we have all the information in front of us, but exactly what that looks like, that's more helpful than doing it abstractly today.
Okay.
That's where I am with it. I don't know if anyone else has comments or questions about this. All right, I don't hear any other comments. So yes, if we could have that in preparation, then we can have that discussion and that vote in June. That would be really helpful.
Okay, we can definitely do that. Yes.
All right, so I know we've been powering through since 9:30. We have one more report, which is short. So I'm I want to defer to folks. Do you want a 10-minute break or do you want to power through and then conclude our meeting? I don't know if anyone has a power through. Okay, I've got to power through. So let's do that. And I think that means I'm giving it over to Glenn for legislative update. And just want to comment, appreciate all the work to get us through the renewal process. It's a lot of work. Appreciate our carriers and Mercer for moving us through that. All right, Glenn, take it away.
Thank you, Siobhan. I will try and make this as brief as possible, but first of all, I just wanted to, in regards to the legislative session itself, right now we are really waiting for a number of our bills, which are either in the Joint Ways and Means Committee or in excuse me, in the House or Senate Rules Committee. The deadline for the second chamber to pass bills through its policy committee is actually tomorrow. And we only have one or two of those bills, but as I said, the majority of ours are in the House Ways and Means Committee right now. One of those bills, which is really top of notice for us, is House Bill 2878. This is the Global Budget Pilot program. I won't go into all the detail of the bill, but it basically establishes a multi-payer regional global budget pilot requiring PEBB and OEB participation. OHA would have ongoing responsibilities, and this would start in January 2028. This was the cost impact was put at about $14 million in the first biennium and $10 million in the second. And there is a number of really extensive PEBB and OEB costs that would come in 28 related to the requirement of providing premium rates above the cost growth target, as well as stop loss insurance and possible impact on our other current plans. This is, like I said, it's in Ways and Means. There are no hearings scheduled yet, but there are internal meetings that are being held right now going on for that. Are there, Ali, did you have anything else that you wanted to kind of talk about this bill?
No, like you said, I think a lot will be better known this week as far as the direction of the legislature, not just on this bill, but in all the bills that are in Ways and Means and obviously on the Senate side. So this one's definitely a big fiscal impact. I think they're looking at how to reduce that. And as Glenn said, there's a lot of discussions going on that we'll be sure to keep the board updated on.
The next one, which is actually good news, is House Bill 3140. It removed the 3-year contracting requirement or RFP requirement for our actuarial and consultant contracts. This was actually enacted. It's been signed, passed the legislature and signed by the governor. It takes effect January 1st, 2024. The next bill, which would is in the Rules Committee, would actually update the eligibility period for elected senators and representatives to the date that they take their oath of office versus the current process for all new employees that come on, which is you begin the first of the month starting later. This has really a cost impact of 465, and well, you can read it through there. This did have a public hearing in rules, and there wasn't a lot of support for it. And so I honestly don't see this making it through because there's only one sponsor. And I don't think the legislature likes to do these type of bills where you give kind of preference for legislators above, the full state staff. Senate Bill 403, this would allow police officers who retire from the Department of State Police to participate in PEBB benefit plans with the same premium cost sharing as they did as an employee. This it's in Ways and Means, no hearing scheduled yet, and it has a cost impact of 13 million in the first biennium and 18 million in the second. And then we're also following about 27 bills, which are either kind of will have a fiscal impact on us, but no, they're not really going to change a lot of our programs in themselves. One to take note of is, since we were discussing as part of the renewal of the MODA's cost copay max program, is Senate Bill 608, and their amendment -A2 would remove the capability for carriers such as MODA to really put in copay accumulator programs such as copay max. And with doing that, well, actually they would have to count third-party payments that, such as your patient assistance program payments that come from the drug companies, and MODA could not administer the copay max program. So with that, and we would lose really any of that, estimated savings that would come from that program. Besides that, we have a bill to expand infertility benefits and removing any cost sharing really on that. We have a bill to just modify the Senate Bill 551 program. House Bill 2002, which I'm sure most people have heard of, would also expand gender affirming care, and then also has some pieces regarding securing reproductive health rights. That's kind of really about it. Again, we're right now waiting to see what Ways and Means is going to do. And as Ali pointed out, that a lot of that's going to be known tomorrow when the revenue forecast comes in. Are there any questions?
Thank you, Glenn. Folks have questions for Glenn. All right, I believe that is all we have on the agenda for today. I need to see if there is public comment. Rose, do we have any public comment today?
No, Siobhan, no public comment.
All right.
Actually, can I just
yes, go ahead.
It's not public comment, but it's really in response to Glenn. So, as Glenn has mentioned some programs that potentially could impact PEBB, and we'll find out more. Any information that we get on those programs and whether it actually impacts the finances of some of the self-insured plans, we will have to incorporate that in between now and then. So that could impact some of the rates that we see. So we talked about trying to make this as final as possible, but if the legislation does change, copay max goes away, we will have to incorporate the loss of the savings, and that would impact MODA's the amount of, I guess, funding buy down that would be needed to make MODA a 10 low cost plan in that case. But we will provide that information as we get it in time for next month.
Thanks, Emery. And Siobhan, just to jump in, we put that on every analysis and fiscal impact that we do if it does have an impact, just so legislative fiscal is aware of the fact. We keep them aware that we have a 3.4% statutory cap. So any legislation that would add cost to that, could potentially reduce benefits in another area. So just wanted to state that. Thank you, Emery.
All right, so we will move on to June with more decisions in front of us and more information about where we are with our rates. So just want to appreciate all of you today for, again, focusing in on the many plan changes that we need to make to serve our PEB members. And again, look forward to seeing all of you in June, and thank you for a very productive meeting, everyone.
Thank you
Great job,
all.
everyone. Thank you
Bye.
so
Be
much.
well.
Bye.